charts, right? Oh, I'm not on it again. Sorry. There's a pointer. Okay, so if you look at it again, I did filter this properly and freely, and I start with 100% in the proximal tubule. The proximal tubules will take up about 50% as reabsorption. Throughout the tubular system, especially the thin portions of the loop of Henry, because I'm trying to concentrate the urine within dipping into the medulla section, I'm going to secrete more of it because around this area, around the tubular part in the medulla, I have more urea around it than what I have inside the lumen, so I can secrete things in it, right? But then I keep circulating. By the time you end at the distal convoluted tubule, look at it, it says 110% remaining. You're like, what, mathematically, what does it mean? Well, I start with 100%, right? I filtered it, but I reabsorbed some of it, then I secreted some more into that filtrate. So by the time I get up to the end of DCT, I have 110% remaining, but then I reabsorb some 70% back again. At the very end, I have this 40%. You might think like, well, if you are going to reabsorb and secrete, etc., why aren't you just like doing it? But the filtration part, I cannot really like 100% control, because once the blood passes through, a lot of small solids will be filtered. The only thing I can do to finalize the job in the tubule, that's what I'm doing. And then the secretion comes from the fact that it's really important for acid-base metabolism and some couple of the small things that I have to maintain that high I guess urea concentration in the medulla. That's why it is like that. So it can be pushed by secretion into the urine side. So this one, just looking into this one and the following one slide, just looks into the parts a little bit closely, the tubular parts. All this is showing here is that we know for sure it passes, urea is going to be reabsorption or reabsorbed by the paracellular passage, and the water will be dragging it, right, as you see. There are maybe like urea transporters on the transcellular pathway. We are not 100% sure what it is called, but there is definitely a paracellular passage in the proximal tubule. When you get to the thin portions, right, we now can talk about these urea transporters. Urea transporter 2 is the first one that we see in the thin portion of the loop of Henle, and then you can go up again. As you can see, this is in the opposite direction, right? This is coming from the blood side into the lumen, so that's the secretion that I do in the deeper parts of the medulla. And then it continues with the ascending limb as well, so both descending and ascending parts of loop of Henle, I'm secreting the urea into the urine. There's a thing about like this flow that we kept talking about. Remember the creatinine and inulin clearance from the blood? It was kind of like constant, so we didn't care so much about the flow. But what happens here, if someone has low urine flow, their urea clearance is going to be, I guess, very readily affected. Meaning that if somebody has a low urine flow, they cannot clean their blood from the urea, so it's going to start accumulating in the blood circulation. That's what it means, right? At low urine flow, when the tubule reabsorbs considerable water and then much of the urea, the kidneys will excrete only 15% of the filtered urea. What did we say on the previous slide? We would like to put out 40% of what it is. So what it tells you, if there's low urine flow, you cannot excrete as much urea that you would like to do, right? So where is it going to go? It's going to back up to your blood circulation. One of the reasons when people have kidney disorders, it's going to start backing up into their blood circulation. The urea numbers, the BUN, will be a good indicator to follow these patients. Okay, this month your BUN was like that, but a month or 2 months later, because your kidneys are getting progressively worse, your BUN numbers will increase because you are not, properly using your nephron. Right? That's a way to follow it. So, yeah, during the progression of renal disease, decline in the GFR creates a low urine flow and then causes an increase in the blood urea nitrogen levels. So this is just to show what we just said, right? It contrasts the behavior of urine, the inulin and creatinine numbers. But what this is trying to say here, right? If this is your normal urine flow, right? What happens is that if urine flow comes down like this, or like urine flow comes down like this, normally typical urine flow was supposed to be here, and then we said about like 40% or of the blood urea nitrogen has to be excreted, but if the flow comes down, then I'm going to excrete much less than that. So the whole idea, flow has to do, it's very important for the urea. And really the main reason is that it's not just the tubular cells, but of the concentration and secretion business that we are trying to accomplish in the medulla area. Alright, all about urea, that's it. The next one is glucose. That's really important, right? Our normal glucose concentration in the blood is about 70 to 110 milligram per deciliter. Because it's a small molecule, it's going to be freely filtered. So whatever I see in the plasma, I'll see it in the urine. It's going to freely pass, I should say in the urine, in the ultrafiltrate, right? It will just filter, but then 100% of it I will reabsorb. So that's what's the idea. What happens is that I have these specialized things called sodium glucose co-transporters. On the figures, you will see them SGLTs, right? These things. It's just a name. Sodium glucose transporter is going to be dealing with, look at this please. I start filtering whatever, concentration, 100% I start. Proximal tubules will take up 98% of it back. At the end of the proximal tubules, I have only 2% of the filtered glucose remaining. And then the rest of the parts will take up. So look at it please, 0% of filtered load remaining, right? So there's a thing about this I want to mention here. In the early proximal tubule and then the late proximal tubule, we see two separate things. So the name comes with like SGLT2 is in the earlier part of the proximal tubule, SGLT1 is in the later parts. But the main difference between the two is sort of their like ratio-wise sensitivity to glucose. What happens is, in the earlier parts, it's like 1-to-1 sodium to glucose ratio they can take. So the sodium is going down the concentration gradient and pulling glucose molecules with itself, right? And then this can create like about 70 times more concentration in the cell compared to lumen, very strong. But by the time I get to the late proximal tubule, the type of channel is so that it's creating this gigantic, difference between the lumen and the cell. Look at this number, almost like 5,000 times, meaning that it's trying to make sure not a single glucose molecule should be left behind in the ultrafiltrate. So I'm trying to take anything that I see into the cells so I can reclaim them back, right? And again, as we talked about this for another context, before, not sometimes because your blood glucose is more than 110 that you should start seeing glucose in the urine, right? Yes, right? We did talk about it. So, yeah, about 110 is like the upper limit. But what can happen? Well, sometimes people have, pick a number, 150 milligram per deciliter. Do we expect to find glucose in the urine?
Sure.
Not yet, okay? So the coming slide, it actually says like 250 milligram per deciliter. After that, all these sodium glucose co-transporters are saturated. You reach the TM number, right? So that saturation number, after that, even if you want to reabsorb, there's no like available co-transporters to take them in. But in clinical reality, it's not 250, it's around 170, 180 level. After that, we will start seeing glucose in the urine. And you are so lucky right now, you're modern physicians, or to be ones, right, in a couple of years, because in the olden days, like, how do you know there's glucose in the urine? You have to taste it, right? Yeah, good. Of course. And the like joke on this was like, and like there was this one professor, like old guy, every year he would do the same joke. You're like, oh, we already heard this from the upper classes, right? But you have to be like nice and smile and stuff. Anyhow, but so he would like bring this urine cup, and then he's like, in our days we have to taste this and stuff. So he dips one finger and licks it. You're like, oh, you're like, and then he's like, aha. As a physician, you also have to be careful because he's like, I dipped this finger and I licked the other one. Like that, right? So, anyhow, it's the joke like that. But now we don't have to taste it. We just send the urine out to be like measured what it is. The idea is like that. So, yes. No, it will smell like urine, but you cannot smell the sugar. You can smell the sugar in the breath because it's a different mechanism, but not in the urine. right? Yeah, that's a good question. So if somebody, like diabetic ketoacidosis, their breath will smell like the sugary, like burnt sugar smell, but it's not in the urine. I mean, you can try, mix it, try to smell it, it's not gonna be there, okay? Okay, so how do we know this? This just slide shows it. What they did, they took a tubular epithelial cell and kind of disrupted to turn them into like this round structure. So what it shows is that if there's glucose present with the, if there's sodium present with the glucose versus no sodium present with glucose, right? Their, I guess, absorption rate into the cell is going to be like, if there's no sodium, the rate is going to be so tiny. But if you put some sodium, those like sodium glucose co-transporters will work through, and then you will see a large peak, right, in the glucose uptake. So it's just to prove the point. The more important slide is this one, right? It again, all the physiology books will give you the number as 250 milligram per deciliter in the blood. After that, you will start seeing glucose left behind in the urine. But again, clinically, it's around 170, 180. But let's say we are looking into this book, this figure, right? What it's trying to show, if this is your plasma glucose concentration, around 250, right, you'll start seeing display, meaning that all the way at this point, there's no excretion of glucose. But after I pass that point, I'll start seeing glucose in the urine because it's excreted, right? And there's this TM number. For this one, please be careful again. These things are really good board questions just to make sure if you are careful looking into questions, right? Because one thing that you see 250 or 180 milligram per deciliter is looking into blood. Versus if you look at this, it says like the plateau, the TM number, as we see here, is 400, but it's not the blood concentration, it's milligram per minute. What they are looking at, they are looking into how you are forming the urine and then where this saturation happens in the ultrafiltrate. So one number, milligram per deciliter, is glucose concentration in the blood. The other one is you are looking into the ultrafiltrate and how it can, use the co-transporters. So what happens is that this 400 number is the plateau number for the, SGLTs to be saturated. After that, they will, you can start seeing that splay happen. So these two numbers pretty much like they translate into the same idea. Whether I reach the 400 milligram per minute saturation rate for the co-transporters, or I have over 250 milligram per deciliter glucose in the blood circulation. After these points, I'll start seeing glucose in the urine. Before, I'm fine, I'll reabsorb everything back again. Another one at the bottom, it shows, right, at low filtered glucose loads, no glucose appears in the urine, clearance of glucose is 0. And again, it's like no-brainer, we kept saying that. But what it is, again, like reiterating the fact, I guess, that until I get to 250 plasma glucose levels, I'm not cleaning anything from the blood, right? The clearance has to be 0 because I'm not taking that glucose, putting in the urine. Only after 250 levels, I start seeing some clearance of glucose that I can talk about. All right, good deal. Then we'll look at some other small things. Amino acids, again, we do not want to pee them out, so 0% of the filtered load should be in the urine. Basically, it's saying that whatever I filtered, I'm going to take back again. So the proximal tubules are the main players for that. So at the end of proximal tubule, I have only 1% of that remaining. What happens is that because some of these carriers, especially in the proximal tubule, are structurally similar to each other, and your amino acids are somewhat structurally similar to each other, so these things can compete with one another. And there are certain autosomal recessive disorders people can have, and it's going to affect their, transport mechanisms for reabsorption, and then you can now start seeing some of the deficiencies of these amino acids. Because pretty much everything will be filtered, you have to reclaim through the tubular parts, right? So competitive inhibition is a thing, and then some of these like glycine, histidine, and non-proteogenic amino acids can be not properly fully absorbed. This is sort of a big table, but what is really important are these last 4 things, right? I couldn't pick one important, that's kind of clinically important. What happens here is that you can have this pre-renal hyperaminoaciduria. Basically, you are putting too much of the amino acids coming in from the circulation, so it overwhelms the system. That's what it is. Arginine is usually the case, so hyperarginemia might be the issue. It will overwhelm the TM, the saturation point. Ornithine one is not that important, so we can look at this. Renal aminoaciduria is a fact. All these things that we see here, anionic aminoaciduria, Hartnup disease is very important, very commonly talked about, asked about stuff. And then this cationic aminoaciduria for the cysteine, these are all autosomal recessive issues, right? What happens is that this amino acid transporter is defective and it impairs the reabsorption, so these people are constantly losing these relevant amino acids into the urine. The one is pretty bad, and there's a thing called Fanconi syndrome and there's a Fanconi disease, so they are not the same thing. But Fanconi syndrome is for all amino acids. So what it is in that case, there's usually an immune or some kind of a toxic attack to the tubular part. So the tubule is not healthy. Because of that, once things are filtered, it cannot reabsorb them, right? So it will impair the function of proximal tubule cells. If it's all the amino acids, it's called Fanconi syndrome. If the second one, maybe if you want to remember, please remember Hartnup disease, right? Neutral and ring structure amino acids, especially phenylalanine, really important, right? You are going to be, losing too much of it into the urine. So things cannot just only come with amino acids, but they can come as oligopeptides. So the way that we deal with them, as a brush border area, like on the lumen side, we have these specialized peptidases and whatnot. So we try to chop down these oligopeptides into smaller amino acids, and then we can reclaim them in that way. Or if you don't deal it in this way, then you can still try to pass them as oligopeptides, like larger molecules, in through the hydrogen exchangers. Once they are inside the cell, then I chop it down into amino acids and then transfer it back to my blood in that way. And if you remember, we kept saying that we do not filter the proteins, but then again, we are not like mechanical stuff. We are human beings and everything is in the cell, etc. ratio happens. So some of the proteins might still escape from these filtration barriers and get into the ultrafiltrate. Then what do? Well, those proteins, I don't have these large protease system in the lumen. I do not chop them down. I pretty much, like with the endocytosis pathway, you take the protein back again into the cell and then transfer it towards the, blood side. So if it happens like that. And I wanted to put it here, like, and underline it one more time, or one last time, I guess, right? Although the glomerular filtration barrier prevents the filtration of large amounts of protein, this restriction is not complete, right? The tubules are the ones deciding who stays, who comes back from urine to the blood side, right? So the tubules are the ones preventing the proteinuria. If you please keep this in mind, then a lot of the nephritic disorders that you study later, we'll look at some of them this time, but a lot more to come. All of these really is going to be for the tubular damage, right? Acute damage to the tubules will create like huge, large, like 3-4 plus proteinuria for the patient. All right, so much for the amino acids and that. How about the carboxylates, right? These are going to be, again, filtered freely, 100% reabsorbed in the proximal tubules. Nothing really to go through mono or dicarboxylates. Everything is taken back with some mechanism. Usually, if you look at them carefully, they are pretty much all like sodium coupled, so concentration gradients will take them. Next one is urate. Urate is sort of important because of the disease called gout, right? If urate keeps accumulating, it can crystallize and start sitting into people's joints, and it's extremely painful, right? You can see this grown-up man crying because of it, because when it really comes with an attack, usually happens into their like big toe. It's extremely painful, and you can always like, yeah, it's extremely painful. Like, did you have a delivery? No, then don't talk about it, right? So, but it can be really painful, as the patients will tell you, because the crystal sitting in the small areas of the joints creates this extreme pain, because all these like free nerve endings are there, seeing how bad it can get. But because of that, we'll say a couple of things about it. So what happens is, 100% is going to be, I guess, filtered. I'm going to take almost all of it in the proximal tubule as a reabsorption, but about half of it, again, I will secrete back. I do some other things along the pathway. About 10% each time I want to leave in the urine so I can get rid of it. It doesn't accumulate. Have you guys talked about these like xanthine oxidase pathways and stuff, how it accumulates or makes up this, the urate formation? No? Again, biochemistry. Okay, so if it's not there, it's coming still. All right, so anyhow, what happens, there are these like anion blocker or inhibitor drugs called BIDS. No one tries to memorize the name because it's like 4 prime, 2 prime, etc., etc., 4 prime, 2 prime, it's like a whole sentence. So we learn it as these drugs. So anyhow, there are these drugs, and then there's probenecid, and look at this one, salicylate. And then they all inhibit the apical urate exchanger, causing urate excretion to increase. So when people take salicylate, right, acetylsalicylic acid, like non-steroid anti-inflammatory drug, the aspirin, if they take it for such long time, it's not only going to affect their stomach, it's going to bother their kidneys as well, because it comes and does a lot of things to mess up the system like that. Another one is really important. There's a drug called probenecid, that's a uricosuric agent. The name tells you, right? Uricosuric means that it tries to put the urate into the urine, get rid of it. So when people have gout, we put them on this probenecid, and you're like this godly creature because you decrease the pain, like almost very immediately. So very effective drug. Anyhow, that's all what it is. About the phosphate and calcium, I want to say a couple things about, because they are really important clinically. So phosphate, again, freely filtered, 80% reabsorbed in the proximal tubule, right? And then at the very end, I come to the cortical collecting ducts and take another, I guess, 10% back. So at the very end, I want to end up with 10% of the filtered load remaining. And of course, if you have a really high phosphate diet, this can be increased. If you have a very low phosphate diet, because the body needs them, this number can be less, right? You don't pee it out at that time. So proximal tubule and distal tubule are important players on that one. This one just looks at it, how this system can be like controlled, right? Proximal tubule, again, very important. The phosphate in either, I guess, shape can be taken into the cell. We don't know how exactly it pushes down. There are some articles talk about this sodium potassium ATPase pump being here, and then the more, I guess, potassium you put inside, you don't want them to activate with these. So there are these chloride channels right next to it. So it's like a complex of neighboring channels allow the passage of it to the blood side. But anyhow, what this is trying to say here, right? From the luminal side, it can be competitive with the sodium binding, because then, depending on how much the sodium intake that you do, you can regulate the phosphate. But if you remember phosphate, it was something we talked about, like maybe the very first week of physiology, right? I know it's like some months ago, but I'm sure you remember some of it. So remember we talked about parathyroid hormone? It was the one, like, we talked about all these like osteoblast binding, rank ligand, osteoclast, stuff like that. So at that point, what we said was, PTH, once it's released, it's going to come to our kidney and then ask that calcium to be reabsorbed at a higher rate. But because calcium has 2 plus and phosphate has 2 minus 2, we don't want them to be freely existing at the same place. So PTH was going to reabsorb calcium and push the phosphate into the urine. But if they happen at the same time together, what's going to happen? They can chelate and give you those stones. So phosphate is usually controlled by multiple different hormones. PTH and active vitamin D are the 2 important players for that. So you can decide how much of it you can put into the urine. So again, it's, as we just show from this slide, right? About 10% we normally put it or leave it behind. So some phosphate excretion happens at the normal levels of plasma. This TM number really has to do with the hormone control and also acid-base balance. Again, acid-base balance has to do with potassium and also has to do, of course it has to do with like hydrogen ions, that's for sure. Hydrogen bicarb, but the secondary players are potassium and also phosphate ions. And this can be regulated because of the acid-base changes. And those things are here listed, right? Not everything, but maybe we can look at it. I just talked about this one, right? Parathyroid hormone will increase excretion of the phosphate because the job of the PTH is to reabsorb calcium. We just said, while it's reabsorbing calcium, it doesn't want free, non-protein bound phosphate to be out there, so it pushes to the urine side, excretes it. Extracellular volume expansion will increase the excretion again, because this time we are trying to hold on to sodium molecules, etc. So it's going to, the play between the two is going to push the phosphate out. And then another one, glucocorticoids will increase the excretion. These people can be really like phosphate depleted in long-term treatment. Another one is down here. Some of the diuretics we looked at, right? They are usually going to increase the excretion of phosphate alongside with potassium ion. If you look at the other side, this is now to increase the reabsorption, so you can like claim this back from the urine and put it back into your body stores. The first one is active vitamin D, right? 125 dihydroxyvitamin. And then another one, we can come here. You can see alkalosis is an important one over here. So if there's alkalosis, it's going to increase the reabsorption. So acid-base issues again will change the level of reabsorption. Alright, oops, sorry. The next one we want to look at is calcium. So phosphate and calcium are really the important two that I want to kind of talk about. If you look at what happens to calcium, it's the numbers that you see, like 65, 25, and then 8. It's somewhat similar to what we talked about for sodium. So it's going to follow that. But one thing please remember, calcium is never like the amount of calcium we measure is not the amount of entire calcium that we have, because calcium never travels by itself. It's a lot of the times it's bound to a protein molecule, right? So if we are not filtering the proteins, when you talk about the calcium filtration, you should like mention the amount, right? So the filterable portion is only 60%. What does it mean? I have this whatever calcium is in the blood circulation, but 40% of it is already protein bound. So I can't filter that anyhow because I'm not filtering my proteins. Out of that 60% could be filtered, about 15% of it is going to be complex with those different things like citrate, phosphate, sulfate, whatever. That other small anions will be like complexing with them. So they will be like traveling together. Right? So what happens is that tubules, once they are, introduced by these calcium, it has to be a free calcium molecule. If it's bind to something else, it cannot recognize it. So this one just shows that the proximal tubule, right, about 65% is being reabsorbed. So they can pass through the solvent drag with the water passage, right, paracellularly, but it also has these epithelial calcium channels to go through the transcellular pathway. So usually the idea, anytime you talk about transcellular passage of any molecule, which means that you have a way with your hormones can come in here and regulate that. Paracellular is usually just like a solvent drag or concentration gradient. So this happens in the proximal tubule. And when we get to the TAL portions, right, we said another 25% can be reabsorbed over here. Again, you can see it passes through the paracellular way and also can be coming into the cells like that. But if you see it, please, about half of it, right, calcium reabsorption happens through the paracellular pathway. Not to go back to this like earlier slide, but we said that electrochemical gradients can be maintained as plus or minuses in the lumen side. So all that sodium passage into the cell and then the back leaks and stuff that happens in the proximal and TAL portion decides what is this number is going to be. So as long as this is like electrochemically positive, it's going to help you bring that calcium into the blood side. That idea can be regulated by hormones. Right? Anyhow, then the later parts in the distal convoluted tubule, right? Even though I'm dealing with small, like 8% filtered load, this is going to be, this specific epithelial calcium channel is going to be the major regulator site for calcium. The previously ones, like the proximal tubule TAL portions, can also be dealt with, but most of the times I come in and try to regulate from here. Again, this whole thing goes back to the idea. Remember, very early on in the PTH stuff, in the bone lectures, we said the blood calcium levels have to be 8.5 to 10.5, or sometimes it says like 8.6 to 10.6, but it's a very narrow window. So what I need to do, when I have hypocalcemia, I don't like release PTH to go crazy and become hypercalcemic. I do it very small increments if I need it. So the same idea applies here. I don't deal with the 65-25%, but I try to use my hormones to deal with this 8% in the DCT levels. Anyhow, this thing I already talked about, right? Parathyroid hormone, what it's trying to do. So it increases the open probability of these apical calcium channels. So those epithelial calcium channels, especially in the DCT, are going to be under the control of parathyroid hormone, because what it is trying to do, I am hypocalcemic, my parathyroid gland released the hormone, it's going directly to my bones, working through osteoblast to osteoclast, trying to resorb the bone to get the calcium out, but at the same time goes to my kidneys, ask these areas to keep reabsorbing at a higher rate so then I can add it to my body stores. Then the third thing it does, it activates the vitamin D. Then my vitamin D goes to my small intestines, and if the bypassing food has any calcium, it's going to start absorbing it. So all I'm trying to do is to fix my hypocalcemia, right? So the same idea, vitamin D will help to the parathyroid hormone. But then again, calcium is really important. I just want to put these 2 extra slides over there just to like make sure we get the point. If there's volume contraction and metabolic alkalosis, it's going to increase calcium reabsorption. So one other place that we see, metabolic alkalosis can put you towards that hypercalcemic state, which is not good, right? Hypercalcemia is not good. Either one is not good, but hypercalcemia is worse than hypocalcemia. Anyhow, high plasma concentration of calcium and chronic phosphate depletion impairs the calcium resorption. You can say like, okay, Dr. Ogun, I understand the first part. High plasma calcium, if it's already there, I don't want to reabsorb further, right? I can pee that out. It's not. But how about the chronic phosphate depletion? Remember, these two things always work like in opposing ways. So if I'm trying to reabsorb calcium, I need to get rid of phosphate. But if the body is in a state that is constantly phosphate depleted, what it's going to do? Well, it's going to hold on to phosphate, reabsorb it, and push the calcium towards the body, into the urine side, so you can get rid of it. So it's going to work like that. And diuretics, right? The ones acting on the TAL, like loop diuretics, furosemide, will decrease the calcium reabsorption. And anything for the later parts, like distal nephron, right, is going to increase the calcium reabsorption. Another one, again, anytime you prescribe furosemide type of drugs, you've got to be really careful. Because we said the first reason was you are dealing with a large percentage of sodium. 25% of sodium is a big deal. You don't want to mess up too much. Another one, now we are adding to the picture, is going to be calcium issues. It was already creating potassium issues as well, so we have 3 things about these diuretics. You have to be really careful. So what this one is showing, right? In the proximal tubule, if there is volume contraction, it's going to increase the calcium reabsorption. At the TAL level, PTH can come. Again, we don't care much about calcitonin. Remember, clinically, you know. So PTH is important, and vitamin D is important. So they are going to increase reabsorption of calcium. So the easy way to like learn these things, you always learn the easy ones, right? If there's less things to memorize, you memorize this. If it's not in your list, then it has to be this one. Right? That's the medical school style. So you just do this one, and then you can then recognize what increases it. All right. So, and it's not too bad. If you just remember like volume expansion and then loop diuretics decreases reabsorption, right? Everything else really increases the reabsorption. You can say it like that. All right. Enough about calcium. The last one is going to be magnesium, and if you look at it. And one thing I want to say here, for this entire lecture, I will not ask you like 15%, 85 remaining, 5% remaining, none of the above. I'm not going to ask you, promise. One thing is that you can look into all of these figures is that what it is that I'm trying to do at the very end. Oh, I leave 5% of the filtered load remaining. So it gives you some idea how you try to regulate these ions. Okay? Again, bless you. magnesium is like the calcium. It's going to be bound to some proteins. So we always talk about filterable portion, right? Filterable magnesium is made up of two parts. Less than 10% bind to those anions, right? And then the rest of it is really bound to larger, I guess, proteins and whatnot. And another 60% is free, so it just goes around as magnesium 2+, so it's readily like filterable and then reabsorbable, if it's a term, I guess, right? So, but again, the bigger player for the magnesium is not really the proximal tubule, but it's going to be the TAL, all right? That's another area. Your loop diuretics, you gotta be careful with the magnesium level. So, you are having a good idea about this loop diuretics, right? It's not an easy thing to just prescribe to someone, send it. It messes up all the very important ions eventually. Anyhow, one thing about this one I want to mention here is this. So this is like pathophysiology kind of communication we can make. What happens in the TAL portion, there is a thing called, like look at this one please, in between the cell paracellular passage. For that to happen, for magnesium reabsorption, we need this thing called paracellin. Paracellin is like a molecule, allows that passage of magnesium from the lumen side towards the basolateral surface. But there's a mutation at the paracellin 1 gene, and it creates this autosomal recessive disorder. Then what's going to happen? Well, if I need that paracellin molecule for me to be able to pass my magnesium towards the blood side to reabsorb, and you have a mutation because of this gene problem, and then the paracellin is not there or it's not properly formed, I cannot take my magnesium. Eventually, this person is going to be extremely magnesium depleted, right? Because they constantly pee it out. They lose it. All right. So some things about the hormones and whatnot. We kind of talked about phosphate and calcium under the role of like PTH, but also PTH will come and increase proximal and distal magnesium reabsorption, because again, magnesium is one of the bigger players for the bone makeup, right? So once you go to your osteoclast and start resorbing the bone, it's not just going to give you the calcium, it's going to give you calcium, phosphate, and magnesium. It's one of the like kind of gives the strength and the hard power to the bone. So PTH kind of deals with that as well, right? And then diuretics targeting the TAL specifically will decrease the magnesium reabsorption. So these patients, in addition to having issues there phosphate, and in addition to having their issues with potassium, they'll have issues with the magnesium. The other ones, especially the osmotic diuretics, are going to reduce the magnesium reabsorption, so they can again pee it out as well. If you look at these, you can reason them out, right? Hypermagnesemia and hypercalcemia. If there's a case that hypermagnesemia already, what the kidneys will do? I'm already hypermagnesemic, if it's a thing. So I will need to pee this out, right? So it's going to decrease the reabsorption, so you don't like keep reclaiming that back to add up to your misery. That's going to be the thing. So it's going to inhibit the reabsorption also. Again, similar to the calcium table we looked at, this one you're not in good luck because either columns are exactly the same, so you can just pick one to memorize and the other one is the other one, right? But again, what it's looking at, similar to calcium, contraction and absorption, contraction or expansion of the volume for the entire like ECF is similar columns. So volume contraction will increase the reabsorption of magnesium, so you want to hold on to the stores. As we said, parathyroid hormone, arginine vasopressin will try to hold on to it, so increase reabsorption. Of course, low plasma magnesium concentration will ask the kidneys to reabsorb more, so you don't lose further. And then metabolic alkalotic states will increase the reabsorption. So again, it's going to increase or shoot up the magnesium numbers for the body, which is not a good thing. And then, yeah, if you learn this one side, please, you can say. This other drug that we see here, amiloride, we also talked about it before. This was the one affecting the later parts of the tubule. So again, it's going to increase the reabsorption. All right, perfect. I have 11:44. We did